In this video, we'll do an exam review on acquired immunodeficiency syndrome. A few important exam questions before the topic. Question number 1. What's the most common cause of HIV transmission? Number 2. What's the function of reverse transcriptase? Number 2. What structures in CD4 cell is required for the entry of HIV-1 into the target cell? Number 4. What's the function of HIV enzyme in CD4 cell? And number 5. What's the most common malignancy and fungal infection in AIDS? HIV, human immunodeficiency virus, causes acquired immunodeficiency syndrome, AIDS. So HIV virus is an RNA retrovirus which has an enzyme, reverse transcriptase. What the reverse transcriptase does, it converts single-stranded viral RNA into double-stranded DNA in the host cell cytoplasm. So a retrovirus, RNA virus which has the reverse transcriptase which converts single-stranded viral RNA into double-stranded DNA in the CD4 cell. HIV-1 is the most common cause of infection in the USA. Infection occurs due to breach in the skin or mucous membrane. Infection does not occur on intact skin. The most common cause of transmission is sexual transmission in homosexuals, and it occurs in more than 75% of cases. So HIV-1 is the most common, and infection occurs due to breach in the skin or mucous membrane and does not occur on intact skin. And the most common cause of transmission is in homosexual due to sexual intercourse and occurs in more than 75% of cases. And the other causes of AIDS are IV drug abuse, body secretion, saliva, blood, urine, semen, transplacental during delivery, and breast milk transfer to the body if there are lesions in the skin or the mucous membrane, or there may be accidental needle or pinprick. Now, pathophysiology of acquired immunodeficiency syndrome. The hallmark of the disease is a profound immune deficiency due to quantitative and qualitative deficiency of CD4 helper cell. So the hallmark of the AIDS is profound immune deficiency, qualitative and quantitative deficiency of CD4 cell. Virus on entry in the body is taken up by the dendritic cell and also by the monocytes and macrophages, which trap the antigen for the B and T cells to initiate the immune response and takes it to the lymphoid tissues to be removed by the CD4 cell. So virus enters the dendritic cell in the blood and also the monocytes and macrophages. They take the antigen to the lymphoid tissue for removal by the B and T cells. So how dendritic cells trap the HIV virus? C-type of lectin receptors on the dendritic cells bind to the HIV GP120 protein that facilitates the union or binding of the CD4 cell with the virus. The viral replication occurs in the dendritic cells in the lymph node, so they become reservoir of the virus in the lymph node. So C-type of lectin receptors on the dendritic cell binds to the protein GP120 and the HIV virus, and that facilitates the union of the binding of the virus with the CD4 cell, and virus replicates in dendritic cells. So they are the reservoirs. The virus is cytotoxic to the CD4 cell, causing loss of cell-mediated immunity. How does the virus attach to the CD4 cell and enters the host cell? The virus envelope protein GP120 that binds to the receptors on the CD4 cell and fuses with it with the GP41 protein and penetrates into the cell and coils, and viral DNA, enzymes and protein are released into the host cell cytoplasm. So this is the HIV virus, and this is the GP120 protein which binds to the CD4 cell, and then the second protein GP41 on the HIV virus fuses fuses with the CD4 cell, and then there occurs penetration into the cell and coiling of the virus. See this, I showed it in purple, penetration and coiling, and then the viral RNA, enzymes and protein are released into the cytoplasm of the CD4 cell. So GP120 binds to the CD4 cell, and then this fuses with the help of GP41 protein with the CD4 cell, and then penetrates and coils into the CD4 cell, and viral RNA, enzyme and protein are released into the host cell. The CD4 cells have co-receptors for the entry of this virus into the cell. The two major co-receptors are 5-CCR and CXCR4 receptors. So this is the CD4 cell. It has two receptors, 5-CCR and CXCR4 receptor here, that combines with the virus. HIV envelope protein interacts with the CD4 and chemokines receptor. Cytokines cause increased cellular activation and HIV replication. Virus is cytotoxic to the CD4 cell. The virus binds to the CD4 cell receptor here with the help of GP120 protein, and then fuses with it with the help of GP141 protein, and then coils into, penetrates into the CD4 cell, where the viral genome, proteins and enzymes are released into cytoplasm of the CD4 cell. So what happens in the cytoplasm of the CD4 cell? The viral reverse transcriptase then act on the genomic RNA and convert into double-stranded DNA, which then, along with the integrase, enters into the nucleus of the CD4 cell through the nucleopores, and this DNA is integrated into the DNA of the CD4 cell, and then mRNA comes out for the protein synthesis, and viral genome comes out and leaves the cell after budding. So I repeat here, in the host cell cytoplasm, viral DNA, reverse transcriptase acts on viral DNA, converts into double-stranded DNA. This is reverse transcription. The reverse transcriptase first forms single-stranded DNA, and then it forms double-stranded DNA, as I shown here, and then it enters through the nucleopores along with integrase into the nucleus and integrates with the CD4 cell DNA with the help of the enzyme integrase, which also enters the nucleus. This pro-virus DNA remains transcriptionally inactive or latent for some time until it activates to replicate the HIV cycle. So how it releases the mature virion? The other enzyme, protease, cleaves the gag-pol from the provirus and converts it into mature virion. See here, this one, protease cleaves the gag-pol to yield the mature, from provirus to yield mature virion. So what does gag do? Gag encodes the protein that forms the core of the virus. So I repeat, viral particle is formed by the assembly of HIV protein, enzyme and genomic RNA at the plasma membrane of the cell, and the enzyme protease cleaves the gag-pol precursor to yield mature virion. A major site for establishment and propagation of HIV infection is the lymphatic system, especially gut-associated lymphoid tissue, GALT. The acute phase that starts after the entry of the virus is flu-like syndrome, lasts from about 2 weeks to 2 or 3 months, and then there is a latent period. Here's the acute phase, and then a latent period of about 2 to 10 years, and then the virus increases and there are opportunistic infection, and then this is the acute stage, which lasts from 2 weeks to 2 to 3 months, and then the virus decreases in number. Latent period is about 2 to 10 years. Then the infections increase due to opportunistic organism, leading to the death. In this period, the HIV virus is increased and CD4 cells are markedly decreased. After the viral entry, there is a window period of 10 days. Signs symptoms of acute flu resembling the features of infectious mononucleosis. Clinical features starts appearing on day 11, and 95% of the patients have features in 6 weeks. So here it's at day 11, the clinical feature starts appearing and reaching a peak, and then antigen P24 appear on day 16 and reaches a peak simultaneously with the clinical features, and then both of them start falling, and immunoglobulin, first IgM starts appearing, then it falls, and then immunoglobulin G, IgG starts, and it maintains a steady state in about 3 months. So P26 antigen appears on day 16, and the 95% of the patients develop P24 within 1 to 6 weeks. So IgM antibodies starts appearing on day 22 and reaches a peak, and then it starts falling, and then, as I mentioned earlier, then IgG starts going up and maintains a peak in 3 months. So 95% of the patients have antibody in 1 month and 99% in 3 months. So I repeat, the window period is of 10 days. Clinical features appear on day 11, and 95% have clinical features in 6 weeks. Clinical features appearing on day 11, and the P24 antigen appearing on day 16, and then IgM antibody starts on day 22. This is IgM starting to appear on day 22, reaches a peak in a few days in a time, then it starts falling, and IgG goes up and maintains a steady state in 3 months. This is IgG antibody maintaining the peak of the clinical features, the peak of the antigen P24. Now, immune system activation. Persistent HIV replication causes increased activity of the immune system. Immune activation is the hallmark of the HIV infection. Cellular activation plays an important role in the replication of the virus. So persistent HIV replication causes increased activity of the immune system, and activation is the hallmark of the HIV infection. And what happens in the persistent activation of the immune system? Number one, activity of the B cell causes hypergammaglobulinemia. Number two, CD4 and CD8 cell proliferation and activation with increased cellular apoptosis. And there is lymph node hyperplasia and activation of the monocytes, increased pro-inflammatory cytokines. Pro-inflammatory and immune regulatory cytokine results in immune activation and propagation of the cellular activation. So in the immune activation, there is increased B cell activity, hypergammaglobulinemia, there is CD4 and CD8 cell proliferation and activation and apoptosis, lymph node hyperplasia, activation of monocytes and inflammatory cells leading to cytokine production resulting in activation. Now, what are the effects of immune activation? Immune function is abnormal in advanced HIV disease. Chronic immune activation causes progression of HIV infection. CD4 infection causes viral spread in activated cell, and cellular activation induces viral infection in the healthy cells. So the effects of immune activation are: immune function is abnormal, immune activation causes progression of HIV, CD4 cell infection causes spread in the activated cells, and cellular activation induces viral infection in the healthy cell. Persistent viremia and activation of the immune system is associated with functional exhaustion and apoptosis. So viremia and activated immune system causes exhaustion and apoptosis, or the programmed cell death of the T cell, CD4 cell, CD8 cell, and B cells. Profound increase in lymphocyte turnover causes increased rate of cell death. So all these factors occurring here. Immune system activation causes progression of HIV, increased CD infection that involves the other healthy cells. Viremia and activation causes exhaustion and apoptosis of the virus-specific T cell. And profound increase in lymphocyte turnover causes increased rate of cell death. Thymus function is also impaired, leading to decrease in cell. Now, the infections associated with AIDS. Which organism causes increased HIV viremia? Among the viruses, it's the herpes simplex virus 1 and 2, cytomegalovirus and Epstein-Barr virus, hepatitis B virus, and adenoma virus. Amongst the bacteria, mycoplasma and tuberculosis, and amongst the parasites, malaria. Plasmodium falciparum infection also leads to increased viral load, which is reversed by malaria treatment, and the deworming causes decrease in viremia. So the viruses involved as opportunistic organism in HIV are HS1-2, CMV, EB, hepatitis B, and adeno. Amongst the bacteria, mycoplasma and tuberculosis. Amongst the parasite, malaria and worms. Mycobacterium tuberculosis is the most common opportunistic organism which infects the AIDS patients, and the PPD, purified modified protein derivative tests in positive individuals have increased HIV replication, and AIDS patients are more likely to develop active tuberculosis and increased viremia. So these are the few sentences about the mycobacterium, that it's the most common opportunistic organism that infects AIDS patients, and the PPD positive individuals have increased HIV replication, and AIDS patients develop active tuberculosis and increased viremia. Remote recall of central memory T cell in an immunized individual is defective. Every T cell function is abnormal in HIV infection. Now, antigen-induced viremia. Antigen-induced viremia also occur with tetanus toxoid, influenza, pneumonia, and other immunizations. Now, role of cytokines in HIV infection. Cytokines play a major role in the regulation of HIV expression in vitro. TNF-alpha causes activation of HIV expression, whereas interleukin 6 and interferon gamma regulate HIV expression in post-transcriptional mechanism. Interleukin 1 beta induces HIV infection at transcription level. There is impaired expression of interleukin 2 receptors. Defective interleukin 2 production reduces expression of interleukin 7 receptors and decreases TNF gamma production in response to antigen. So amongst the cytokines, TNF-alpha causes HIV expression, interleukin 6 and interferon gamma regulate HIV expression in post-transcriptional mechanism, and interleukin 1 beta also induces the infection at transcription level, whereas impaired expression of interleukin 2 decreases its production. Now, organ system involvement in HIV. The main organ system involved in AIDS are skin, eyes, lungs, and CNS. CNS is the most common extranodal site of lymphoma, and the most common fungal infection in CNS in AIDS is cryptococcosis, and in the eye, the blindness is due to cytomegaloviral infection. In the lungs, pneumonia is caused by pneumocystis, Gervasi, and strep pneumonia. And in the skin, most common malignancy in AIDS is kaposi sarcoma, which has red raised non-purpuritic lesions, and Burkitt's lymphoma due to EB virus. Amongst the organ system involvement in the CNS, lymphoma is the most common extranodal malignancy, and the most common fungal infection in AIDS in CNS is cryptococcosis. Blindness also due to CMV infection, pneumonia due to pneumocystis, Gervasi, and strep pneumonia. And in the skin, most common malignancy in AIDS is kaposi sarcoma, Burkitt lymphoma, also caused by the EB virus. Now, the diagnosis of the HIV infection or AIDS. After the viral entry, there is a window period of 10 days. Signs symptoms resembling the features of infectious mononucleosis. Clinical features starts appearing on day 11, and then antigen P24 appear on day 16. Immunoglobulins, first IgM starts appearing on day 22, and then IgG starts going up and maintains a peak in 3 months. So 95% of the patients have antibody in 1 month and 99% in 3 months. Plasma P24 antigen level increases before the increase in anti-HIV antibodies. So plasma P24 is the first to increase. So I repeat, the window period is of 10 days. Clinical features appear on day 11, and 95% have clinical features in 6 weeks. Then P24 antigen appears on day 16, as here clinical features appearing on day 11, and the P24 antigen appearing on day 16. And then IgM, the acute phase lasts from about 2 weeks to 2 or 3 months, and then there is a latent period of about 2 to 10 years, and then the virus increases and there are opportunistic infection leading to the death. HIV virus is increased and CD4 cells are markedly decreased. In advanced disease, there is leukopenia thrombocytopenia, lymphopenia, the low CD4 cell count, and CD4 to CD8 ratio is less than 1. So the patient must have a CD4 count of less than 200 cells per cubic millimeter. Lymphopenia, low CD4 cell count, and the ratio CD4 to CD8 is less than 1. There is hypergammaglobulinemia due to immune activation due to B cell stimulation by the EB virus. Now the screening test is Elisa or enzyme immunoassay EIA. It detects antibody for both HIV-1 and HIV-2. It becomes positive for anti-GP120 antibody. The test is highly sensitive, more than 99%, but lacks specificity, especially in immunized patients with tetanus toxoid and influenza and other vaccines. So the screening test ELISA detects antibody for both HIV-1 and 2 for anti-GP120 antibody. It's a highly sensitive test, more than 99% positive, but lacks specificity in the immunized patient with TT and influenza. EIA, enzyme immunoassay, detects antibody for both HIV-1 and HIV-2, and it detects separate HIV-1 and HIV-2 antibodies and antigen results. Causes of false positive are antibodies to HLA antigen. Multiple transfusion may also cause false positive results, and recent influenza immunization. False negative ELISA occur in recent infection when there is a window period in the first 10 days. It may give a false negative ELISA result when there is hypogammaglobulinemia, advanced HIV infection. Now, confirmatory test for the AIDS is Western blot test. So what does it do? It confirms the HIV infection by becoming positive for different types of antibodies to HIV infection like HIV-1 and HIV-2. Western blot test detects antigen in samples using specific antibodies that react with the HIV antigen. In the Western blot test, there are antibody bands against the antigens of HIV. The test is positive when there is presence of any two bands against P24, P41, GP120, 160 antigen of HIV. The test is negative when the bands are absent and indeterminate if any other combination of bands is present. 95% of patients have antibodies to HIV by 4 to 6 weeks, and more than 95% have seroconverted by 3 months. Now, HIV blood test. HIV blood test detects actively dividing viruses and is more sensitive test for the diagnosis of acute HIV infection. HIV can be cultured from the tissues, blood, and plasma. So the HIV blood test detects actively dividing virus and is good for the diagnosis of acute viral infection. The nucleic acid test, NAT test or RNA test. The NAT test detects HIV in the blood 10 to 30 days after exposure to HIV. It's also known as polymerase chain reaction. Now, treatment of AIDS. Multiple drugs act at different stages of the viral replication, and they include inhibitors of fusion and binding. Number 2, inhibitors of reverse transcriptase. Number 3, inhibitors of integrase, inhibitors of protease, and maturation inhibitor. Why HIV-1 treatment is difficult? HIV-1 has multiple genes which code for proteins which modify the host cell to enhance viral growth and regulation of the viral gene expression. And number 2, different drugs act on the different stages of viral replication in its cycle. Now, the protocol for HIV testing and diagnosis. Screening test EIA detects antibodies for both HIV-1 and HIV-2, as I already mentioned, positive in 6 to 10 weeks for anti-GP antibodies. Is highly sensitive in more than 99.5% of cases. So if this screening test is positive, then HIV tested in Western blot test. If HIV-1 is tested in Western blot test, if positive, diagnosis confirmed for HIV-1 infection. So if the screening test and Western blot test are positive for HIV-1 test, the diagnosis is confirmed. If HIV-1 Western blot test is negative, then perform the HIV-2 EIA A, the screening test, and if the test is positive, HIV-2 Western blot test is done. So if that's positive, then the diagnosis is confirmed for HIV-2 infection. If in this case, if HIV-2 Western blot test is negative and if clinical features are positive, repeat the test in 3 to 6 months or repeat the screening test in 3 to 6 months for both HIV-1 and 2. So here is the pictorial picture. The screening test, HIV-1 and HIV-2. HIV-1 tested, if positive, HIV-1 Western blot test done, if positive, diagnosis confirmed for HIV-1. If the test is negative or if the Western blot test for the HIV-1 is negative, then HIV-2 Western blot test is done. If positive, the diagnosis is confirmed for HIV-2 infection. If negative, repeat the screening test in 3 to 6 months for both HIV-1 and HIV-2. Now answers to the question. What's the most common cause of HIV transmission? Most common cause of transmission is sexual transmission in homosexual, and the incidence is more than 75%. Number 2, what's the function of reverse transcriptase? Reverse transcriptase converts single-stranded viral RNA into double-stranded DNA in the host cell cytoplasm, and then it's integrated into the host cell DNA in the nucleus. So reverse transcriptase converts viral RNA into DNA. This is known as reverse transcription, and reverse transcriptase first forms single-stranded DNA and then it forms double-stranded DNA. Question 3. What structure in CD4 cell is required for the entry of HIV-1 into the host cell? CD4 cells have co-receptors for the entry of HIV-1 into it. The two major co-receptors are 5-CCR and CXCR4 receptors. Number 4. What's the function of HIV enzymes in CD4 cell? Reverse transcriptase in the cytoplasm of the CD4 cell converts single-stranded viral RNA into double-stranded DNA. As I already explained, first it forms single-stranded DNA and then double. Second enzyme is integrase. Integrates viral genome in the CD4 cell DNA, and protease cleaves the gag-pol from the provirus and converts it into mature virion. See here, this one, protease cleaves the gag-pol to yield the mature, from provirus to yield mature virion. Question number 5. What's the most common malignancy and fungal infection in AIDS? The most common malignancy in AIDS is kaposi sarcoma, and most common fungal infection in CNS is cryptococcosis.